Welcome to Series 5 of the Lassie Lounge podcast. Join me, Katie Taylor, as we talk balancing hormones, busting myths, breaking taboos, boosting libidos, and bolstering confidence. Why not grab a coffee, take a seat, or go for a walk and join us in the Lassie Lounge as we chat all things midlife, menopause, and beyond. With thanks to our friends at Youth and Earth for making this podcast possible. Your pelvic floor is an incredibly important part of the body that very often doesn't get the attention it deserves. Incontinence, painful sex, and constipation are all embarrassing symptoms of a weak pelvic floor. But on occasion, poor pelvic floor health can result in more serious issues such as prolapse. All of these issues are extremely common, particularly after pregnancy and childbirth, and are absolutely treatable, but aren't openly discussed often enough, and many women suffer unnecessarily in silence rather than seek help. So I'm delighted to be able to speak today to author, pelvic floor specialist, and creator of the AB system, Kim Vopni. Kim Vopni is a speaker and a women's health educator, known as the Vagina Coach. She is a certified fitness professional who became passionate about spreading information on pelvic health when she was pregnant with her first child. Welcome, Kim, and thank you so much for joining me today.
Thank you for having me. Always nice to spend some time with you.
Yeah, now, in our last podcast series, we spoke to continence nurse specialist Jane Simpson about the basics of pelvic floor health. But today I thought, what would be really helpful for everyone is if we could focus perhaps on what's probably one of the most uncomfortable and awkward conditions that can affect a woman, and that's pelvic organ prolapse. So I just thought maybe you could start off explaining what actually is a prolapse and what are some of the telltale signs to know if you've actually had one or are suffering at the moment.
Yeah, absolutely. And, statistically, incontinence is about 30 to 40% of women. And we see a lot of ads that market to us for pads, but prolapse is 50%. It's more common and there is no conversation around it. So people are often really sidelined when they get this diagnosis. So what essentially is happening is inside of our pelvis. Let me show you a model here. Here's our pelvis, and inside we have our organs, which I'm going to take out and kind of show you their alignment. But this is kind of how they would nestle inside of our pelvis. This is like textbook anatomy, right? Everything obviously shifts around a little. The important thing to remember as a point is we are dynamic beings and there is movement inside our pelvis with the fascia, with the muscles, with the organs. So it's not like they sit in there like this as in a cement block, so to speak. But underneath we have the pelvic floor muscles, but this is essentially the arrangement. Here's the bladder. Here's the vagina. So the vagina is like a tube, and we have the uterus and the cervix on top and the fallopian tubes, and then we have the rectum at the back. Okay, so that kind of gives you a little bit of an outline of anatomy. So when the bladder, the uterus, and or the rectum start to shift out of their proper anatomical position, and again, there is some variance in there, there's some normal movement, but when it becomes more permanent, they start to bulge into, so the front wall or the back wall, or in the case of the uterus, descend into the vagina. So I'll give you another bit of a demonstration using my shirt sleeve. If you can imagine that this is the tube that we talked about with the tube of the vagina. So the pelvic floor muscles would be under here. We'd have the uterus on top, the bladder, and the rectum. And so in the case of the bladder, if it starts to shift and drop, it'll bulge into that front wall of the vagina. So it creates a bit of a bulge, a bit of a pocket there. And then as it progresses, it can come down lower to the entrance to the vagina, and even there could be a bulge outside. So it's not the bladder bulging out, it's the wall of the vagina because the bladder is pushing on it. And then on the back wall of the vagina, the same thing can happen with the rectum. So the rectum can bulge into the back wall of the vagina. And then in the case of the uterus can descend from the top down into the vagina. So that's essentially what a prolapse is. And as I said, 50% of women, I've had a stage 2 uterine prolapse. I've also had a stage 2 rectocele. So the rectum bulging in the back wall. I've also had my uterus descend down from the top.
And for those who are listening to this as a podcast, we will be uploading this onto YouTube and onto our social media. So you'll be able to see the sort of visual examples that Kim has just been showing me now, which is very helpful when you actually see sort of where they are placed and where they should potentially be sitting. So what triggers a prolapse? I mean, is it to do with childbirth or being overweight or menopause, or is it a combination of all these things?
Yeah, life really. So there's lots of things that can contribute to the development of prolapse, and pregnancy and childbirth are definitely known contributors. Constipation is also one. Chronic coughing is another. And oftentimes, even if you have never been pregnant, even if you have never given birth, even if you have given birth via cesarean section, not vaginal birth, you still can develop a prolapse. So as I mentioned, there's lots of different contributing factors that could potentially lead to somebody developing prolapse. And it can take sometimes many, many years. And early stage prolapse is often asymptomatic. And now there's a new grading, sort of a new classification that is even considering that small, what was considered a stage 1, almost normal now, especially in people who are, approaching menopause and moving beyond. So there's lots of different causes, or contributors, I would say. Perimenopause and menopause, so our transition into our postmenopause years, we have the hormonal influence. So when we have a decline in estrogen, the tissues in the vagina, the tissues around the urethra, the tissues around the bladder, they love estrogen. And when we no longer have it circulating, the tissues become thinner, they become drier. There's less resilience that can contribute to less support. So part of the role of the pelvic floor muscles is support. Part of the role of estrogen is some tissue resilience in there as well. So that can exacerbate potentially an already existing prolapse, or it could be the time where things develop for the first time. And during that sort of perimenopause transition, there's a lot of fluctuation in hormones, and sometimes there may be a bit of dryness, but we don't necessarily, there's so many other things going on. And a lot of it can also influence our digestion, which contributes to a lot of people dealing with more constipation, which can then be another exacerbating factor. So if I was to kind of pick a couple of the top ones, pregnancy and childbirth, chronic coughing, and chronic straining from constipation are huge contributors.
Yeah. And I mean, is it inevitable, or can we sort of stop it in its tracks before it gets too bad?
Yeah, we absolutely can. With like the pelvic floor has received so little attention, and really, when you think of all of the stages of life that we go through, especially as women and female bodies, how we have never been told at an earlier age is really kind of shocking when you think about it. The menstrual cycle, pregnancies and childbirth, perimenopause, menopause, all of those things have a really significant influence to the pelvic floor. But a lot of times, because it's not talked about, because it's not something, like I always think it should be a vital sign, our pelvic health should be a vital sign, but nobody's checking in on us about our pelvic floor. And if anything is said, it's usually do your Kegels, make sure you do your Kegels. Well, make sure you do your Kegels. And no one's teaching them to us. Nobody's evaluating our pelvic floor. So we are going through life kind of not really sure what to do. And then when symptoms become so they interrupt our quality of life so much, then we start to seek help. And it's never too late, but oftentimes we're then prescribed medication or sent down the surgical path, which those are great options to have, but they shouldn't be our first line of defense. Really, we should be taught preventive strategies throughout our life. But that's just not yet happening. So I'm not going to say that it is just inevitable. What I will say is we have the power to start today and pay attention to our pelvic health, kind of like we pay attention to the skin on our face. We invest a lot in therapies and serums. We wash our face. We put makeup on. We have all of this care for the skin on our face, and we're neglecting a part of the body that deserves equal, if not more, care because it manages our continence. It supports our organs. It plays a role in our sexual response. It's the foundation of our core. It supports our spine and pelvis, like really, really important jobs. And it gets neglected. And so we can step in with pelvic floor physical therapy. I think that we should be seeing one every single year, just like we go to the dentist for our teeth. That's another thing we do. We brush our teeth twice a day, we floss, we go to the dentist once or twice a year. We should be doing the same thing for our pelvic health. Then do your pelvic floor exercise, vaginal estrogen in the early postpartum, and also in the kind of as we're approaching menopause transition earlier if indicated. Vaginal moisturizer, potentially supplementing with collagen. But I would say for me, pelvic floor physical therapy and a consistent pelvic floor exercise practice. And I incorporate it into whole body movement. So it really can happen in about 10 minutes a day.
Yeah, I mean, it's amazing, isn't it? I guess it's like all areas of women's health. It's so it's so underfunded, under-researched, under-talked about. And I think the earlier we talk about all these sort of women's health and gynecological concerns, the better. I mean, it should be on the school curriculum, on the medical school
1,000%.
and yeah, and we should be, checked. We're all sort of given a sort of bounty bag here in the UK after we give birth, and we're sort of told what to expect. But then there's this vast sort of gap between, for those who have given birth between then and menopause. And as you say, it's often too late. I mean, from some of the women you've seen, throughout your career, how has a prolapse sort of impacted on their lives? And, what should we be concerned about?
Mm-hmm. So as I mentioned before, early stage prolapse can be asymptomatic. And that's part of the reason why I think we should be seeing pelvic floor physical therapists every year for screening. When it becomes a little bit more advanced, the symptoms can really be quite bothersome. So there could be back pain, a sense of heaviness and dragginess in the pelvis, especially as the day goes on, feeling like you have something stuck in your vagina, maybe difficulty with insert of sex. So you can absolutely have insert of sex if you have a prolapse, but sometimes the bulges might be uncomfortable. Difficulty emptying the bladder. So where that bladder bulges in, there's a little bit of a pocket where urine can get trapped. And the backside, the poop can get trapped. So that can make voiding, especially if somebody's already constipated, voiding is even harder. If somebody is still menstruating, there could be difficulty inserting a tampon, or tampons could get pushed out. So those are all not super fun to deal with. And the other piece is there's one of the most common words I hear is I feel broken. And the influence and impact to the mental health with a diagnosis of prolapse is much greater than I've seen with say incontinence. And it sort of halts people in their tracks. And sometimes they're told they can't run, they can't jump, they can't lift anything over X pounds. They get this big, long, don't do this, don't do this, don't do this list. And that people who love exercise are thinking, well, now what am I going to do? And so what they use exercise to help their mental health. Now that's been removed falsely, but it has been removed from what they think they are capable of doing. So there's a huge influence to the mental health piece. Another practice that I didn't mention earlier, kind of in the pelvic health exercise bucket, is something called hypopressives. It's also called low pressure fitness. And this is a specific technique that has had a really, really powerful impact on prolapse. And some people, myself included, have even reversed their prolapse. So there can be a reduction in symptoms. There can be an elimination of symptoms. There can be an improvement in the stage of prolapse, specifically bladder and uterine, most likely. And that can remove what is contributing to the decline of the mental health component. And it allows people, it's just such a freeing feeling when you feel the pressure lifted off your pelvis, and when you can feel day to day that your symptoms are getting better. And coupled with a sort of Kegel type practice, the two together really build a lot of resilience in the pelvic floor. And just as a quick sidebar, I don't agree with you can't lift, you can't run, you can't jump. I think we have the capacity to do whatever we want when we train the pelvic floor and progressively load it and build resilience. Sitting and avoiding movement does not build resilience anywhere in your body.
Yeah, and look, you're touching now on these sort of lifestyle and treatment interventions. So, for those that perhaps don't know what a Kegel is,
Mhm.
or don't know about pessaries or vaginal estrogen, can you talk us through the sort of different treatment and lifestyle interventions that women can, women that already have prolapses
Mhm.
or perhaps getting there can do to help, improve things?
Mhm. Yeah. So if you have the capacity geographically, financially to see a pelvic floor physical therapist, I think that would be always my number one thing. The next would be to avoid constipation. So work on improving your gut health and whatever you need to do to make sure you're pooping without straining and you're pooping every single day. Kegel exercise, there's people think they know how to do Kegels, but nobody's ever really totally sure. They're a bit of an elusive exercise. They involve a voluntary contract and lift and let go of the pelvic floor muscle. So there's sort of a range of motion that the pelvic floor muscles go in, just like my arm. If it's down at my side and I want to do a bicep curl, I curl my hand up to my shoulder. That's the range of motion that I'm working on there. Same thing happens in the pelvic floor. And what people interpret as being a Kegel is a squeeze. And so they often use their inner thighs. They might use their butt cheeks or their glutes. They might sometimes even hold their breath and bear down, which is the opposite of what we're trying to do. And if you can see a physical therapist or if, like physiotherapist, physical therapy is the same thing, but a women's health physio, to have your pelvic floor evaluated, they use gloved fingers to assess your pelvic floor. That's the gold standard for me. If that's not available to you, you have your own fingers. If you have a partner, or if you happen to have a male partner, they could use their fingers and or their penis. And when there's something inserted inside the vagina, that gives you some feedback. And then you can say, okay, I'm going to use some of the cues that I learned. One of the more common ones is imagine picking up a blueberry with your vagina and your anus, or imagine sipping a smoothie through a straw with your vagina. So what you should feel on your fingers, or what your partner would feel if you have a partner doing it with you, is there would be a little bit of a hug of the fingers. So sort of a closure around them, and then a bit of a draw up. So not like you're not trying to suck the fingers way up and in, but just a gentle drawing up motion. And then there's a release. So that's what we should feel and what a physio would be feeling for as well. There are also biofeedback devices that can be helpful, but they're usually about $200. So again, if you have $200 and you are close to a physio, I would put your money to the physio first before going to a device. But things like the PeriFit or the LV can also be helpful tools. So that's a Kegel, and that builds some. It really focuses on trying to build up strength and endurance and sort of reaction time of the pelvic floor muscles. And I will emphasize that you really need to make sure you've got the relaxation component in there. It's not just about a squeeze and a hold. We need to have that full range of motion. Then I mentioned hypopressives. So that's another practice that I think is really tremendous. Pessaries are like an orthotic. So if you wear shoes with arch supports or orthotics in your shoes, a pessary is essentially an orthotic for your vagina, where it's inserted. There's different shapes and sizes. And when they open up inside, they apply pressure to an extent and support to the walls of the vagina and any organs that are starting to shift out of their position. If you're using a pessary, especially if you are kind of approaching menopause, 1000% you would want to have vaginal estrogen in there as well. Even if you are not using a pessary and you are around the time of menopause, I do evidence absolutely supports the use of vaginal estrogen. It's very safe. And this is inserted into the vagina, stays locally, and affects the tissues there. And that would be for the rest of our life. So pelvic floor physical therapy, pelvic floor exercise practice that includes Kegels with whole body movement and hypopressives, pessaries if indicated, vaginal estrogen, and avoiding constipation.
And what about things? I assume things like smoking and being overweight have make some impact on our pelvic floors.
Yeah. So smoking, many smokers will have a cough, and cough is a big contributor. Chronic coughing is a big contributor to pelvic floor dysfunction. Not to mention systemically the status of our tissues when we are smokers. So we have way more inflammation in our tissues, which can irritate the bladder, which can contribute to degradation in our tissues. So absolutely stop smoking for so many reasons. Um, and what was the other one that you said? I'm sorry, I
Well,
lost my
being overweight.
being overweight.
Yeah,
Yes.
I mean,
Yeah. So if like the pelvic, all the muscles in our body, but the pelvic floor, especially because it's so central and it is a lot of people call it like a bit of a hammock. It's a supportive hammock type shape, I guess, if you want, or a bowl. And it manages all the loads that we do throughout our day. And if we have, maybe when we're pregnant, we have an increasing load as we become more pregnant. If we are putting more body mass on our body, that can also increase the load that pelvic floor needs to manage, which can be a contributor to some increased symptoms as well. So, yeah, so staying at an optimal weight, stopping smoking, looking at inflammatory, whether it's products we put on our body, products we consume. Certain foods can be irritating to our bladders. They won't, maybe they'll constipate us. So there are lots of things that we can do. It's not just, oh, go do Kegels. It's a much bigger conversation.
yeah. Now, look, you've talked about, I mean, you being able to almost sort of reverse it, but for those where things have got pretty bad, you were talking about all the different stages. When does surgery become really the only option? And also, be worth reassuring women, because there's been a lot of horror stories, obviously, in the media about the mesh and various other sort of surgical interventions that haven't perhaps gone well or haven't lasted a lifetime.
Yeah. So surgery, I get asked a lot about when is the right time to have surgery. And there there isn't really a this is the perfect time to have surgery. It's sort of if the symptoms are interfering with your life to such a degree that your quality of life has declined and you have tried all of the conservative approaches without success, then I think that is absolutely a time where you should be considering, well, I shouldn't say should, you could be considering surgery. Surgery is not mandatory for any of this. People live with stage 3 and 4 prolapse with pessaries, with estrogen, with exercise, and they are choosing not to have surgery. And so that is absolutely possible. I chose surgery for my rectocele. So I was able to reverse my stage 2 uterine prolapse. All of the things that I did, I worked at it for 9 years and I couldn't bulge no pun intended, couldn't change the status of my rectocele. And it was really interfering with my life. And so I made, it took me 4 years actually to make that decision. I'd considered it for 4 years because I felt like a bit of a hypocrite. I felt guilty. I felt like I haven't tried hard enough. There's lots of emotion around that as well. Pelvic organ prolapse is an injury, like an ACL tear or like a rotator cuff. Like it's an injury, and there are things we can do to support it if you don't want to. But having surgery is not an indication of failure or that you're giving up. It really, truly can be transformative. However, what I will say is all of the things that I just talked about, the conservative approaches to helping improve or manage prolapse, become your prehab. So if you have tried all of those things and they get to the point where, nothing is really changing, it's still interfering with the quality of life, all of those things have helped put your body and your pelvic floor in a better position to undergo surgery. And all of those things are going to be part of your recovery and ongoing pelvic health. So some people think, well, once I have surgery, the symptoms will be gone and it won't bother me anymore. I won't need to do pelvic floor exercise, or I can go back to doing all the things that I did before. And I argue that we need pelvic floor exercise even more after we've had surgery. And the removal of symptoms can absolutely be liberating. And that's what we're all really hoping for. But we can't just throw caution to the wind. We have to appreciate that there were contributing factors that led to the development of that prolapse. So I want to make sure I have those in check. And I want to make sure that I continue to maintain resilience in those muscles now, because I have some scar tissue there that I need to consider that can sometimes interrupt function. So surgery is a great option, but you absolutely need your prehab. You need your recovery protocol in place, working with a pelvic floor physio. And this is an ongoing management, really, of your pelvic health, which we all should be doing anyway, even if you don't have surgery.
Yeah, and what before I let you go, one
Mhm.
more thing that we get asked a lot in our Facebook group is that there's a lot of women who have had either cesarean sections or they've had hysterectomy, and they do notice a sort of bulge in the pubic bone at the front, and they just assume that that's sort of a post-surgery bulge. Is there anything that can be done towards that, or is that just, you know, part and parcel of a sort of post-operative, I guess, look, you know, cosmetic look at the end?
Yeah, so you're sort of talking about the shelf almost, where
Yeah,
it's like the abdomen. Yeah.
yeah.
So we have the capacity, our bodies have the capacity to constantly adapt and change. And what I would say for that is working with a pelvic health physio. I know I say that ad nauseum, but they really truly are such a valuable health resource for us. They can help with the scar tissue. So sometimes it's the scar tissue, the adhesions that have been left behind from an incision, which we need to have. That's part of the healing process. But when the tissue becomes stuck and rigid, it restricts blood flow, circulation, and um, can alter the appearance. Sometimes it can change the way that our muscles are working. And when we can, the physios use manual therapy techniques to help kind of ease and mobilize that scar tissue to help improve blood flow, circulation, and muscle reaction. That in and of itself can sometimes change the appearance, but also working on the muscles around. So the deep abdominal muscles, the transversus abdominis is the deepest layer. It co-contracts when we do a pelvic floor contraction. So when we imagine picking up our blueberries with our vagina and our anus, what we should feel in our body is a gentle tensioning in between our hip bones, kind of just above the pubic joint, a gentle almost drawing inwards of the abdomen. A lot of people have been to an exercise class and they'll say, engage your core, or they may say, pull your belly button to your spine. And the intention of that cue is to get the transversus to turn on. And while it is well intended and can be a great cue for some people, I prefer to come from the bottom up. So when we can activate the pelvic floor and get that co-contraction of the deep abdominals, that's truly an engaged core. So next time you're in an exercise class and they say engage your core, do your Kegels, pick up your blueberries. That's really what's going to help. So that I would work with a physio, mobilize scar tissue, check out your posture. So posture can change sometimes with pregnancies or surgeries, and then optimize your pelvic floor through exercise. And just one more thing before I leave that topic, hysterectomy, just as a sidebar, removing the uterus is kind of like a keystone organ. It actually, the uterus and cervix play a role in helping keep the vagina, the top of the vagina, up in place. And when it's removed, so when we have a hysterectomy, especially if it's because of a prolapse, it leaves us at an increased risk of other types of prolapse. So obviously we couldn't have a uterine prolapse anymore because the uterus is gone, but we are at a greater risk of a bladder prolapse or a rectocele, or what's called a vaginal vault prolapse, where the top of the vagina starts to sort of almost cave in on itself and start to, this sounds extreme, but turn inside out of itself almost. So that's an important consideration for people who maybe have had a hysterectomy or are considering a hysterectomy. You want to make sure, again, you've addressed root causes as to why are you having, there's like fibroids and cysts, there's all sorts of reasons why somebody may be having a hysterectomy, but find a surgeon and ask them how they re-secure the top of the vagina. So there's one technique in particular called the McCall's culdoplasty. There's other techniques and names, but essentially they are ensuring that the top of the vagina is secured, and that can help reduce that increased risk of prolapse after a hysterectomy.
Yeah, that's really helpful because I hear that a lot from a lot of women who are worried about post hysterectomy, you know, and how comfortable or not comfortable life will be, whether it's sort of sexual health or you know, as you've been talking about here, prolapses. Now, for anyone that's listening, I've interviewed Kim before about general pelvic floor health at the Midlife Festival. So you can watch that back at www.themidlifefestival.com. Kim's also written some brilliant articles and some lovely illustrations of that blueberry on our website, which is lattylounge.co.uk. But Kim, you've also written a brilliant book, and you have a website as well, and obviously you're on social. So where can people find out? Well, first of all, what's the book called?
Yeah, thank you. The book is called Your Pelvic Floor, and it's published by Watkins Publishing in the UK. You can find it online, Amazon, any of the major book retailers do carry it. My website is vaginacoach.com, and I'm on pretty much most social media platforms. If you go to Google, put Vagina Coach in there, you'll find me somewhere.
Absolutely. And I keep staring at, for those that are listening and not watching, there's a brilliant puppet behind Kim. Well, I don't know if it's a puppet, but it's a fabulous.
Yeah, the vulva puppet. Yep.
Yeah. So it's a good opportunity for you to have a look on YouTube, what we're talking about. Well, Kim, thank you as ever for joining us and sharing your wisdom. That's been so helpful. And as I said at the beginning, if anyone's struggling, please do, right, you can email us or contact us, and we can always put you in touch with Kim's website and her book too. So take care, and I hope everyone found that helpful. Thanks. Thanks, Kim. Bye.
Thank you.
Thanks for listening to the Latte Lounge podcast. Please subscribe wherever you're listening so you don't miss our next episode. For more support with all things menopause and midlife, head to our website, lattelounge.co.uk, and search for the Latte Lounge group on Facebook. This podcast was sponsored by Youth and Earth and produced by Emily Crosby Media.